During this period of COVID pandemic, we can see that basically telehealth and remote monitoring has greater significance. And in the realm of cardiovascular monitoring, there is cardiac rehab, there is arrhythmia detection, there is hypertension management, diabetes management. So I'm going to focus on 3 devices that are not exactly novel, but they are actually available currently, and I have had experience with them. So I'm going to talk about the wearables, especially for arrhythmia detection. I'm going to talk about this Ecg Duo device and an Angiomat device. So let me start with the next slide. Okay, the principles of wearable devices. First, there is this activity sensor. So wearable devices has several sensors, type of sensors involved. And the first is based on this principle that physical activity is inversely correlated to adverse cardiovascular outcomes. So generally, the sensors are triaxial accelerometer, which measures the linear acceleration along 3 different planes. And also there's a gyroscope, which measures angular motion. And together with the GPS and barometers, then this allow more accurate assessment of physical activity and positioning. Next. The second important one, especially to me as an electrician, is the heart rate and rhythm sensors. We know that high resting heart rate is associated with a poor outcome. Impaired heart rate recovery after exercise also correlates with adverse outcomes, and low heart rate variability. And nowadays, all these 3 can be easily measured. We can measure through single-lead ECG. There's also Photoplatysmography, also called PPG. And in this case, the PPG measures changes in microvascular blood volume that translate into pulse waves. So the emitter actually sends out a continuous pulse of photons and then measures the variable reflection from the tissue. And this generates a pulse wave. And through the analysis of the pulse wave, we can make an analysis to show whether there's arrhythmia or normal heart rhythm. Finally, there's also a blood pressure sensor. Currently, there's a FDA-approved heart guide wristwatch from Omron, and it uses a wrist cuff. And you can see that the study shows there is actually very little difference in their measurements compared to conventional sphygmomanometer. Nowadays, there are more and more products that can measure blood pressure without the use of a cuff, and they employ the principle of pulse transit time, which is the time required for the pressure wave to travel from the heart to a certain vessel. There's also another principle of arterial tonometry, whereby the sensor is actually placed adjacent to an artery, usually the radial artery, and from there they can make measurements. Unfortunately, none of the BP monitoring devices at the moment have sufficient data to promote its use in widespread population. So you can see here, this review paper shows that there are several devices out there, but in terms of the approved wearables for medical use, we have the Apple Watch, we have the BioBeat watch that also can do heart rate monitoring and also cuffless BP. There are Fitbit activity trackers, but Fitbit Sense is also able to do ECG, and recently the Samsung is also approved for ECG monitoring. So first of all, the major use of all these wearables have been tested in atrial fibrillation screening. And you can see, I'm going to move on to AF. It's just going to talk about AF generally. It is one of the most prevalent test arrhythmia that we have recently, and it is going to be the pandemic as the population ages. In this region, we are relatively low prevalence. However, it may be related to lack of studies and lack of screening programs. AF being a progressive disease it may be asymptomatic in the beginning, and as you can see, as you age and there is more comorbidities, you can see that the atrial fibrillation increases over the years, and when we see them in secondary care, we are usually detecting them at late stage. So there is a rationale for screening them at an earlier stage. So from this meta-analysis, you can see that patients who have asymptomatic atrial fibrillation actually has worse outcomes. So you cannot see the readings, but the red boxes indicate the bad outcomes in several of the studies when they present with asymptomatic atrial fibrillation. Again, another study comparing incidentally detected atrial fibrillation versus no atrial fibrillation, and you can see that there is an increased stroke risk of 4% versus 1%, and increased mortality risk as well. Next. AF now is so there's such a good pathway to manage atrial fibrillation. So we now call it the ABC pathway. A stands for anticoagulation to avoid stroke. B is for better symptom control. Nowadays, we have better modalities and also better treatment to enable rhythm control, such as ablation, such as drugs. And C, we are also recognizing that there are cardiovascular risk factors that need to be managed to better control atrial fibrillation. So you can see in summary, screening for AF has several benefits, including the prevention of strokes, early detection and treatment of atrial fibrillation, hopefully improving the outcome. And you can see the risks of atrial fibrillation may be just anxiety and possible over-investigation if there are abnormalities detected. The ESC guidelines to screen for atrial fibrillation suggest opportunistic screening for AF by pulse taking. So any patients coming into clinic for whatever condition, if they are above 65, is a good opportunity to take their pulse and assess whether they have atrial fibrillation. In terms of systematic ECG screening, it is now suggested for people who are aged 75 years and above, and there are several screening trials and programs that will promote this. So the number of devices that have been able to diagnose and monitor for atrial fibrillation have really exploded in the past years. You can see on the bottom left-hand corner our conventional Holter that involves several wires and device hanging over the neck. Now that is really rarely used, and it's now instead replaced by the one that is next to it, the patch. Now with a patch, we can even monitor patients for up to 2 weeks. And of course, you now know that there are many other consumable devices, such as the blood pressure monitor that is able to alert to atrial fibrillation. There are many mobile phone apps, as well as smartphones, as we have seen. And this is the study that is performed in 2019 by, it's called the Apple Watch study. Almost 500,000 people were recruited, and this is based on 0.5% of them received notification of an irregular pulse, 3% in those over 65 years old. 20% of them went on to have ECG patch monitoring, and there was a diagnostic yield of 34% to detect atrial fibrillation, giving a positive predictive value of 0.84. And the adverse events related to the app and is 1.5% anxiety. Equally, the Huawei Watch study have screened also nearly 200,000 patients, and in this study, 0.2% received notification of suspected atrial fibrillation. Subsequently, 87% of them was confirmed to have atrial fibrillation by doctors, and they went a step further in this study whereby 95% of them then entered into the integrated care program, which is called the Mobile Atrial Fibrillation App, based on the ABC pathway. So how do we view wearables detection of atrial fibrillation? So this is a wearables tools survey, and you can see that physicians, mainly cardiologists and electrophysiologists, were asked to review these two tracing. One is a single lead ECG and one is a PPG tracing. A 58-year-old female with a CHA2DS2-VASc score of 3. And they were asked whether they would diagnose AF based on this tracing. So on your left, you can see the single lead ECG tracing, and on the right, you see a PPG tracing. Unsurprisingly, physicians are more comfortable to diagnose atrial fibrillation based on a single lead ECG, and 83% would diagnose atrial fibrillation. However, only 27% were happy to diagnose based on a PPG tracing. And you can see the PPG tracing, there are a few plots there. One is the tachogram, which shows the heart rate. The other one is a Lorenz plot, which is very typical for atrial fibrillation. They went on to ask if they were diagnosed, would they be treated with anticoagulation? And the answer is yes, only in 72% and 68%. And they wanted further investigations through 12-lead ECG and 3-lead ECG. I can foresee that this is going to change over time as physicians get more used to the wearables and the interpretation of Lorenz plot and heart rate plots. So this is an example of what you get from a PPG tracing on the left, and ECG on the left, and a tachogram. And on the right-hand side, you can see sinus rhythm in a heart rate plot followed by atrial fibrillation. And bottom is the Lorenz plot that differentiates between the sinus rhythm versus atrial fibrillation. So practically, we have been able to use the Apple Watch or any of this wearable to help us diagnose many patients. So these are practical examples whereby on the first one on the left is a patient who is actually niece of a member of staff, and we were unable to document her palpitations for several months until she came back with this using her Apple Watch. And you can see that this is a regular broad complex tachycardia, which was subsequently diagnosed to be SVT with aberrancy, and she had it ablated. On the top right, this is an example of atrial fibrillation, again with aberrant conduction that is detected. And finally, on the right-hand side, bottom, you can see that this patient again had symptoms that were undiagnosed for several months before he came with this tracing from his wife's Apple Watch, which showed clearly that there is a PVC. The Apple Watch can also be used to generate 12-lead ECG. So there is a paper that shows how you can generate 12-lead ECG using the Apple Watch by placing the watch in different positions of the heart. And you can see now in this case, there is ST elevation seen in, so really it refers to lead 1. You can see ST elevation in a lateral MI. You can see ST depression in an inferior MI. But the Apple Watch is not very sensitive in detecting an anterior MI. Okay, I'm going to skip past this. I'm going to talk about the next device, which is the Echo Duo. And this is actually a novel acoustic stethoscope that is, you can see on the right-hand side, there is a diaphragm with 2 electrodes adjacent to it. So it's able to do 2 things. One is to create an electrocardiogram single lead, as well as a phonocardiogram and with artificial intelligence to aid in the analysis. So we know that murmur detection is poor among physicians and also among cardiologists, but this device has almost 90% sensitivity and specificity in detecting murmurs. Okay, and what it does is you have an app that where the echo hardware can transmit the data through Bluetooth and is uploaded to a cloud and get analyzed automatically, and you get a notification whether there is a murmur detected or not. And I understand that actually Farrer Park Hospital is having a pilot program using this device in collaboration with GPs. And there's actually a science to this. So in terms of the acoustic cardiography, more well documented in this device called Audicore, you can create a 3D sound fingerprint. And you can see that in this case, there's S4, S1, S2, and S3. There are several, There are several parameters that are used in this acoustic cardiography. Next, okay. So for example, the EMAT is the time required to generate force by the LV to close the mitral valve. And this is related to the acceleration of the pressure in the LV. And there are certain parameters such as SDI and the presence of the third and fourth heart sounds that can help to diagnose heart failure. So there are several applications. In fact, they may be even more accurate than BNP in predicting impaired LV function. So with a sensitivity of 88% versus 80%. Presence of a third heart sound also indicates a likelihood ratio of 5 times more likely to predict LV heart failure. Finally, I'm going to talk about my last device, which is an Angiomat device. This is actually an implantable device. In general, we have still not been able to predict heart attack. While we have many risk factors to manage and to optimize, we are not able to detect heart attack in patients easily. And usually, we talk about door to balloon time and symptom to door time. So this is an implantable Angiomat Guardian device that is like a pacemaker. It has a lead that goes to the heart, and this device is able to perform continuous ST monitoring. And it has 2 types of alerts: an emergency alert that will, when it detects significant ST changes, and there's other alerts because it's also able to detect abnormal heart rates, tachycardia, bradycardia, and also other system-related alerts. Next. So in the alert study where it is able to detect asymptomatic MI, so silent MI may be detected in these devices, and it increases the positive predictive value of ACS. So compared to patients who depend on symptoms alone, there is a significant increase in the positive predictive value. And also, because of the alarms that come from these devices, there is a significant reduction in the time to sort of the door to ACS time. So basically, patients present earlier, and in terms of all ACS, and especially for STEMIs and non-STEMIs. They are also able, as I said before, to detect other conditions such as atrial fibrillation, bradycardia, and bundle branch block. Finally, in terms of patients, we know that there are many patients who present with a false positive chest pain. They are able to also reduce that. So this is actually been approved by the FDA in high-risk patients with risk of recurrent ACS. While this is still invasive, and I think this is not going to be the final product, there will be likely improvements. In Singapore, where we were fortunate to be involved in the first 7 cases of implantation done in Farrer Park Hospital, and this is the first commercial available in Singapore. Okay, so I hope I've given you an overview of 3 possible novel devices that are actually present in Singapore that we can use to help better manage our cardiac patients. Thank you.